All right, welcome everyone. We're so glad to have you join our so-called Palo Alto virtual Parkinson support group meeting this month, our last meeting of the year. And we actually have three speakers today. Our first main speaker is going to be talking for, about 40 minutes or so, and then answering questions. And we have Dr. Miglis for up to an hour of his time today. So we're glad to have him. Our first speaker is Mitch Miglis. He is an autonomic disorder specialist at Stanford in neurology, and he's also a sleep disorder specialist. So he knows a lot about a couple of the issues that plague people with Parkinson's disease and similar disorders. And I also noted online that Dr. Miglis is involved in the long COVID research efforts. So that's very interesting too. Maybe you could say a bit about that towards the end of the talk or something. And I see that I need to fix the chat. So I will fix the chat. And if anyone has questions, use the chat once I get it working, or submit through the Q&A box. And I will interrupt Dr. Miglis's talk to ask him certain questions. So thanks for joining us, Dr. Miglis, and everyone called in today. Thanks.
Okay, thank you, Robin. Okay, so thank you for the introduction. And so today I am going to speak on a common issue in Parkinson's is orthostatic hypotension and kind of managing blood pressure issues. And orthostatic hypotension is just the fancy medical term for meaning your blood pressure drops more than it should when you stand. So a lot of patients with Parkinson's have this, maybe 50%. Some patients also have big swings in blood pressure, highs and lows, and we can get into that. So before getting into what happens when the process doesn't work correctly, it's important to understand what normal is. So normally when we stand up, there's almost a liter of blood. So it's a good amount of blood, maybe a sixth of our, or a fifth of our total circulation is distributed from, most of it is in the stomach area and the upper and the torso area, and it gets distributed into the legs. So all that blood kind of goes into your legs. But the body has mechanisms in place to make sure that the blood pressure stays fairly constant. And so we don't faint when we stand up. And so we call this the barrel reflex. Basically, there are areas in the brain and blood vessels in the brain and the neck that sense these changes in pressure, and they'll send signals to blood vessels in your legs to squeeze down, to pump that blood back up, to increase your heart rate, so the blood circulates up to your brain when you stand and you don't faint. And so when this doesn't happen correctly, we have this condition called orthostatic hypotension, or we can abbreviate it OH. And OH is defined by a drop in your blood pressure systolic, so that's the top number, by at least 20 points. It can also meet this criteria if the bottom number drops at least 10 points. The top number is usually more important. The top number is correlated more with the blood flow to the brain and a lot of the symptoms that you might have. So usually when we're seeing patients, really focusing on that top number. And so that top number should not drop more than 20 points when you stand, but it's important to note that this implies that the drop is sustained. So it's normal for that pressure to drop right away when you stand, but it should normalize within, at least 30 seconds and definitely within a few minutes. So there's a cutoff here that if the blood pressure drops and it stays low for at least 3 minutes, that's abnormal. So if you're testing your blood pressure at home, if any of you have seen us in our clinic, we have a blood pressure log we give. We recommend doing your first reading actually laying flat, and we'll get into this, and then you'll stand for 3 minutes and check it again. Because if the pressure drops right away, but it rebounds, normal. But if at 3 minutes it's at least 20 points below where you started, that's not normal. That's orthostatic hypotension. So they're all different causes of OH, and not all of them are Parkinson's disease. So the more common causes are other medical issues, heart failure, being dehydrated, being anemic. And as we age, it's quite common. 5% is a low estimate. Some people have estimated it's up to 20% once you get about over age of 65. And there's a lot of reasons for this. Increased varicose veins, decreased muscle mass, medications that patients are on, medicines that lower blood pressure. All of these can cause drops in blood pressure. So there's a few ways we can help distinguish those more medical causes from causes like Parkinson's, more neurological causes. It's also important to recognize that not everyone with orthostatic hypotension has symptoms. And especially in Parkinson's, sometimes if you have symptoms, it's not easy to recognize the symptoms. Some patients will have a drop in blood pressure, but they won't have any symptoms. And some people will have really severe symptoms. So this condition can be asymptomatic, can be without symptoms, and we really only treat it if there are symptoms associated. So it's important to look for it, and probably when you see your Parkinson's specialist, they do these measurements of your blood pressure sitting and standing. But if your pressure does drop, we're only going to treat it if you have symptoms or if you have frequent falls. That's another kind of red flag that it could be related to your blood pressure. If you do have symptoms, what are the common ones? Well, definitely dizziness, lightheadedness, feel like you're about to faint. Some people do faint. Your vision could get blurry, blackout, whiteout, loss of peripheral vision. Other symptoms that people don't know so much about, but these are also pretty common, are what we call coat hanger headache. So that's sort of pain in the shoulders and the neck area, and this is due to decreased blood flow to these large muscles in your neck. Shortness of breath when you stand, sometimes chest pain. Some people get more cognitive slowing and trouble thinking. This is pretty common. And fatigue, if your fatigue is much worse when you're standing, and it gets a lot better when you sit down or lay down, then you want to make sure you don't have orthostatic hypotension. So, we call all these symptoms orthostatic intolerance. So it can be lightheadedness, but it can also be these kind of more vague symptoms of fatigue or shortness of breath or just not feeling well. And if you have symptoms like this that are obviously worse when you're standing and you lay down, they get better or go away. This is something you want to look for. Any questions about the symptoms? I'll just keep going, but if anyone has questions, feel free to just write those out. We can stop at any point.
Somebody asked about this. You talked about if the fatigue is worse when standing, then they should get the orthostatic hypotension change. Somebody mentioned that standing itself for a long time, seems to be problematic. Their legs start to hurt and they don't feel well if they're standing for a long time. And is that normal?
Yeah, it's not normal. I mean, I think that could, it's not necessarily going to be caused by a drop in blood pressure, but it's enough of a concern given how common this is. I would definitely do some blood pressure measurements. And again, I would first check blood pressure laying flat, get that reading, and also write down your heart rate, and then try to stand in place for 3 minutes and check your blood pressure and your heart rate again. And do that once a day for a week. Different times of day are good. Usually this problem is going to be worse in the morning, when you're more dehydrated. But get some measurements in the evening and afternoon and once a week, and then bring that to your doctor. I mean, if you have a symptom like that. Yeah. So this can be diagnosed at home with these home blood pressure measurements. You don't need to come in and do fancy testing, but we do this testing in the Autonomic lab where we measure blood pressure with a little finger monitor. We do a tilt table test, and this is common. We'll see the blood pressure drop from, this is a normal blood pressure, 120/85, pretty quickly on upright positioning, it's going to drop down to 68 over 55. Um, what this is showing on the top, this is a measurement of blood flow in the brain in this particular patient. And this is meant to show that blood flow definitely drops when the blood pressure drops. So the cerebral blood flow goes down, but it doesn't go down as much as it would in, say, like a 20-year-old with this degree of blood pressure drop that didn't have any medical problems. The, the brain in Parkinson's, in patients that have this low blood pressure issue chronically, it seems to adapt. So the body preserves blood flow to the brain at the expense of the rest of the body. So your pressure in your arm, it's not the same as the pressure in your brain. And patients with chronic orthostatic hypotension are able to do a lot of things that wouldn't be possible in someone who didn't have this adaptive process, because their brain has been adapting to this for so long. They're shunting blood flow more to the brain and away from the rest of the body. So this may be why we sometimes see these huge drops in blood pressure, but patients don't notice symptoms, or they're not so mild, not so severe, is because of this kind of preservation of blood flow to the brain that happens. So again, there's two types of OH. There's the non-neurologic or non-neurogenic, and then there's the neurogenic. The non-neurogenic causes, which also are really common, I think, in the population of Parkinson's just due to age and other medications. So you always want to look for these things. Make sure you're not anemic. Make sure you're staying hydrated. If you have cardiac conditions, that can contribute. Adrenal insufficiency is pretty rare. Your doctors would probably have clued in and check that. There'd be other features. Varicose veins can cause it. And then if you have this problem, the first step is going through your medications. And if you're on any medicine to lower your blood pressure, that would either be lowered or stopped. And that would also include nitrates, things like Viagra, those sorts of medications, and even some antidepressants like tricyclics. These are things like nortriptyline, amitriptyline. So we get this all the time. This is real common. Patients have high blood pressure most of their lives, develop Parkinson's, develop orthostatic hypotension, and then the first thing we do is take them off of one or two of these antihypertensives. So again, what causes this condition? Well, the Parkinson's disease is caused by deposition of this protein of alpha-synuclein in the brain, and that causes all of the motor symptoms. But that protein also gets deposited in peripheral nerves, and including the nerves that control the release of chemicals that keep your blood vessels doing what they're supposed to do. And so the protein is deposited in these autonomic blood vessels that release this chemical norepinephrine or noradrenaline. That chemical binds to your blood vessels and causes constriction when you stand. So the Parkinson's protein causes breakdown of this release of the chemical. So the blood vessels don't constrict, blood pressure drops. And again, I mentioned the prevalence. It's about 30 to 50% of patients with Parkinson's have this condition. This is also orthostatic hypotension is also a feature of the other, Parkinson's like conditions like Lewy body dementia and MSA. So very, very common. And it's important to recognize because it's really a source of a lot of, morbidity, a lot of, worsening of quality of life, and also mortality. Patients with Parkinson's that have this orthostatic hypotension, they're in the hospital more, they have more falls, and because of that, there's greater risk of complications from those falls and death. And the hospital-related costs are 2 to 3 times higher in Parkinson's patients that have OH versus those that don't have OH. And it's also very treatable, so that's why it's just important to recognize if you have it, it can be treated, and thus it can lead to significant improvement in other neurological functions. So, when to suspect it? If you're having frequent falls, which can be due to other things in Parkinson's, but that should always cue you into, looking at your blood pressure. Any of those symptoms that we discussed that are worse when you're standing, and then also if you have any other comorbidities like heart disease or diabetes or kidney disease, and if you're on any medications that can lower your blood pressure, you always want to think about this.
And I see on the first bullet point there is the word syncope. If you could define that and say what it means in this.
Yep.
And
Yeah, thank you. So syncope means fainting. So any fainting, you want to make sure that it's not due to orthostatic hypotension. Fainting can be, normal in certain circumstances. It's about 1/3 of the population can faint or has fainted. The most common cause of fainting is called vasovagal syncope. That's just this reflex that happens, sort of the body's response to stress that happens very quickly. But people can also faint from orthostatic hypotension, which is more of a gradual decrease in blood pressure. It just kind of keeps going down the longer you're standing, and then you faint. Usually that doesn't happen with orthostatic hypotension because it's a gradual decrease, and by the time people are getting close to fainting, they're recognizing symptoms and they'll sit down. But yes, people can have syncope from it, which means fainting.
thank you.
Okay, so how do we evaluate this? So we get all these symptoms, we think of this might be an issue. We do these blood pressure measurements. So measure supine, which is laying flat, and then measure it after you've been standing for 3 minutes. And then there's a couple other blood tests that we usually do. These are standard tests your primary would do, mostly just making sure you don't have anemia, B12 level. That's something we always check for, like everything neurological. So make sure your B12 level is okay, and make sure your thyroid's okay. But there's not a lot of other blood tests that we do. And then if you have access to autonomic testing, like at Stanford, that can be useful to just sort of quantify it and do the tilt test. And then we also do other breathing tests that measure autonomic function. But it's not always necessary if you just do the measurements at home and you're seeing that you obviously have this blood pressure drop. So it's not just low blood pressure. So almost everyone that has orthostatic hypotension also has high blood pressure when they're laying flat. So those centers in the brain that control the blood pressure, they're also not working correctly when you're laying flat. So they should be lowering pressure when you're flat and then increasing pressure when you're upright. But they're not working correctly because of Parkinson's. And so what you'll have is when you lay flat, like when you're sleeping, your pressure will be high. So we call this supine hypertension. And the first step in treating this is try to raise your head of the bed at night. And I'll show you a slide on this, but we always recommend raising the head of the bed by around 30 degrees and to lower blood pressure while you're sleeping. And this can also help your morning blood pressure from dropping so much. So what can happen is if your pressure is high at night, that's going to push more sort of fluid out of your blood vessels, and you're going to end up urinating more of that fluid in the morning, and your blood pressure will drop more. So if you can keep your nighttime blood pressure more in the normal range, your morning pressure is not going to drop so much. So there, there's a couple reasons to treat this if this is going on. Okay, so really the important things, how do we manage this? Again, the goal is not to totally normalize the blood pressure. That's never going to happen. It's really to improve symptoms that you're having and quality of life and reduce falls and all that. If you don't have symptoms, we don't treat it. All right, so skip this. So yeah, so really before you use medications, first steps are elevate the head of the bed. It's really best if you can get an electric bed, just to raise the head up. In the past, the old school method was putting something under the head of the bed, like bricks or telephone, books when they used to make those, and or like risers to get the whole bed up, but then you tend to slide down the bed. So if you can afford an electrical bed where just the head goes up, that's the best. Compression garments, I wouldn't recommend prescription grade intense compression stockings. They're really uncomfortable. They're really hard to get on with Parkinson's. So usually just knee-high, like over-the-counter athletic socks can be useful. If you're really symptomatic, the best compression is an abdominal binder. So you just buy these Velcro binders, like for low back pain. You can get like $10 on Amazon, and you just put that around your belly and just kind of keep it a little tight. And so most of the blood that goes into your legs is in your abdomen, so it'll just kind of keep that blood from pooling as much. Fluid, the goal is around 2 liters of water a day. Another really helpful sort of tip is drinking water quickly. So boluses of water, you have to be about half a liter, maybe 6 to 8 ounces of water. Will also be okay. So if you drink that quickly, especially if it's cold, it's going to increase your pressure by up to 30 points top number. So the staying hydrated throughout the day is one component, but then also you can drink water very quickly, and that'll give a sort of rapid bolus effect, and you can almost use that as a medication. Like in the morning, if you're able to drink some water quickly before you get out of bed, if you're lightheaded in the morning, that can help. And it has to be water. It's not an electrolyte solution. This is actually a reaction in the stomach that happens to the water itself if you drink it quickly. And then salt. This is the only time that doctors are recommending to increase your salt, but salt's going to help keep more of that water in your blood vessels, and you want to aim for about 2 teaspoons of salt per day to the diet. So 2 teaspoons of table salt. And then exercise. So strengthening your legs, exercise is important in Parkinson's disease. Anything you can do to keep your leg muscles strong is going to help pump blood up to the head. But I'll show you a slide on that. So this is just, showing the head of the bed. This is the picture on the left was from, I think, one of the first publications on this from, I think, the 1940s, and this is how I used to do it. And this is a much more comfortable way to do it now. So exercise. So if you have orthostatic hypotension, your blood pressure is going to drop when you exercise. And I've seen patients, unfortunately, they're referred after they fainted, on a treadmill in the gym. You really want to avoid treadmills if you have this, but the point is, normally blood pressure goes up when you exercise, but if you have orthostatic hypotension, it's going to drop. And so you just have to be a little careful when you're exercising. It's definitely better to do things where you're seated, stationary bike, rowing machine, or in a pool. So if you're in a pool, you also have the pressure of the water, which is going to increase your blood pressure, and you might be able to do more and be less symptomatic if you have really severe OH. And then there are what we call counter maneuvers, which is basically squeezing your muscles. So the best thing you can do if you're feeling like you could faint is to sit down or lay down. But in some situations, you might not be able to do that. So the best thing you can do is maybe cross your legs and squeeze your leg muscles, or squat down. Some patients, if they're in the grocery store and they feel like they're going to faint, they can't sit down, they'll squat down and pretend like they're looking at something, or so these things will increase your blood pressure, but they're obviously temporary maneuvers. So any questions about the non sort of medication treatments for this?
Somebody asks, it used to be that if you felt faint, you sit down and put your head between your knees. This person says, I don't see a picture of that.
Yeah, that's true. I I don't know why they didn't include that. Maybe because yeah, it might be a little unsteady if with your
Okay.
head between your knees squatting, especially if you have other kind of balance issues from Parkinson. So if you can do that, that's fine. If you don't have, you're not going to fall down. But the best position is really just laying on your back and putting your legs up.
Right.
And the second best is squatting probably, and then the third best is crossing your legs like that.
And one thing I have seen previously, I don't know if this is considered a counter maneuver or not, but doctors often advise to pump the ankles before standing up to get, I guess, maybe get blood moving up the leg. Is that considered a counter maneuver? I guess you wouldn't really do that if you felt faint because you're already seated.
Yeah. It's not a counter maneuver, but it will start the blood circulation a little bit more in your calves. It's probably going to have a minor effect. It's, just the calves, so
Mhm.
really it's a lot of this is the quads and the glutes and those muscles that you're trying to activate. So,
Right.
yeah.
Okay. Somebody says, my mother has had acute OH for the last 45 days that included several falls and up to 10 OH incidents per day. She has just been released to skilled nursing from her fourth hospitalization, but PTOT don't want her to leave the bed because of the fall risk. Are there
Yeah.
exercises and options for bedbound people?
Yeah, that's really tough. Yeah, the physical therapists, they never want to touch our patients because either high or low blood pressure, and they get really scared. She probably needs, I mean, she definitely needs medication, I think, that's at that point, it sounds like it's pretty severe. So, I'll get into medications next. And she really needs medication to increase it first so she can get out of bed. But I mean, the PTs would be the best to kind of answer that question. There are probably some pretty basic core exercises and things she could do, but it's not going to really help dramatically. I mean, the first step is to use medication and then get out of bed and do the conditioning. Yeah,
Okay, thank
yeah,
you.
yeah. Um, so I think that question just kind of summarized this slide is, why do we want to treat this? Is because the symptoms lead to falls, which leads to hospitalizations, which leads to deconditioning, which then leads to fear of falling, and then it's this vicious cycle that we want to prevent. So this is a really really busy sort of technical slide, but um, this kind of shows all the different medications we use for this. If you want to look on the right here with this blood vessel here, the most common medicine is probably called midodrine, and this medicine binds to the receptors on the blood vessels and causes them to constrict. And this is a good medicine. It's usually the first one we start. It's shorter acting, so it's going to last like 3 hours at a time. So usually take it 2 to 3 times a day. Other common one you'll see is called fluticasone or Florinef, and that's a once a day long acting drug, and that causes retention of more salt. So it's just going to increase the volume in the system. Um, Longer acting, so there's a greater problem with that high blood pressure at night, that supine hypertension, but also a decent option. Droxidopa is the newest drug called Droxidopa or Northera. It's more expensive, but it's recently gone generic, so it's become less expensive now. And this is probably the best drug overall because it's the cleanest. It's converted to the chemical that causes the blood vessels to constrict. Um, it's really similar to midodrine. It's 2 to 3 times a day dosing. Um, and so typically we'll try mitogen first because it's easily accessible, and then try to think about droxidopa and kind of see how much that's going to cost under the insurance plan. And then finally, there's pyridostigmine or mestinon. This is a good drug. It's just not as powerful as the other ones, and it's going to increase upstream sort of chemicals that are eventually converted to that norepinephrine that causes the constriction. So this is mitogen. Again, sort of older school drug, approved in 1996. Acts about 3 hours at a time. Side effects are higher blood pressure at night. The more common ones patients notice, it can cause an itching or a tingling in the scalp, because it causes this goosebump sensation. It can sometimes cause urinary retention, and that can be an issue in Parkinson's. And sometimes it causes headache. Then droxidopa, approved in 2014. And again, a lot of this is sort of more scientific stuff. You don't need to know all of this. It's very similar to mitogen in the dosing. Side effects are pretty similar. It doesn't cause the urinary issues or the goosebumps. It can cause headache and then higher blood pressures at night. So a lot of doctors get really nervous about either high or low blood pressures in patients with this problem. Really, we're really focusing on the low blood pressure. I mean, the priority is to increase that pressure when you're standing, so you're not miserable and you're not falling and you're not fainting. And then we kind of accept that there's going to be a little more risk of this higher blood pressure when you're laying flat. But there have been many studies, and it seems like all of the major medical complications of this condition are related to the low blood pressure. And then, yes, the high blood pressure can increase some risk of kidney issues and heart issues long term, but it's orders of magnitude kind of lower than all those risks associated with the blood pressure drops. So again, to try and reduce those risks of high pressure, we raise the head of the bed, and then sometimes we'll even give a short-acting medicine to lower the blood pressure at night, and that can be done as well. So, if your doctors are really kind of nervous about these medications, again, the emphasis is that there's not been a lot of studies showing great risk of the supine hypertension. It's all of the problems are related to the orthostatic hypotension, the low blood pressure.
One question, or one person pointed out that their family member takes HCTZ or diuretic water pill. What are your thoughts about those?
Yeah, I mean, not good if you have orthostatic hypotension. So you should stop that if they have orthostatic hypotension. As far as using that at bedtime, if you have supine high blood pressure, that's reasonable to do, but it's going to probably cause you to go to the bathroom, more often at night, which is already a problem. So they're probably better drugs if you were going to pick something to just give as needed at night. Something like clonidine or labetalol are ones that we use. Yep.
Okay, let me see. I think I had, oh no, that's it. Thanks.
And so then the other point, if you're taking one of these medications like mitogen or droxidopa, is obviously because it increases blood pressure and because there's this greater risk of supine hypertension or high blood pressure, you don't want to give the last dose within 4 hours of bedtime. So usually, if it's 3 times a day, we're dosing it first thing in the morning, around lunchtime, and then maybe later afternoon. And then again, this is mentioning you can give these shorter acting medicines to lower blood pressure at bedtime if needed. Fluticasone, that one that I said that is long acting and it increases salt absorption, probably has the most side effects. It can cause swelling in the ankles. It can cause low potassium. It is increased increases risk of complications generally. So probably because it's real long acting. And so this is usually something that you don't want to be on first thing. I mean, it can be okay to take, but if your doctor prescribes this first thing, you want to maybe ask about alternatives, and midodrine or droxidopa are probably better. Pyridostigmine, again, this can be a good drug. It's usually an add-on. So like with midodrine, it works pretty well in combination because it's not as strong by itself. It's really good also if you have really slow motility, like gastroparesis or slow emptying or constipation, because it's going to speed that up. And that's one of the side effects is diarrhea. But if you're constipated, that can be a useful side effect. So yeah, that's those are all my slides. And I think the point is that this is a really common complication. The symptoms can be vague at times, and you really want to, sometimes you have to keep a diary and just really see, are the symptoms related to standing and just being on your feet? And then when in doubt, there's really a low threshold to do blood pressure measurements. And then I can maybe even put the link to our log in the chat. We have a blood pressure log on our website that you can download. And then if you're seeing consistently that your top number is dropping 20, 30 plus points, and you have symptoms with that, then you want to bring that to your doctor. You want to go through your medications, make sure you're not taking those drugs that'll make this worse. You want to increase your fluid and salt, use some compression garments, elevate head of the bed. And then if that's not working, you have 3 or 4 different medications that usually we can get the blood pressure under pretty good control, so patients aren't super symptomatic, and the fall risk related to this is a non-issue. So yeah, with that, I'll stop there and go through questions.
Okay, I have a few more questions for you. Somebody asks, how high can the blood pressure be before worrying about OH to take medications to bring down the blood pressure? Above 170, above 200?
Yeah, I usually tell patients 180, top number 180. If it's not coming down within 5 minutes, because part of this problem is with these diseases, there's just so much fluctuation. You might check it 5 minutes later and it's going to drop considerably. So if it's still 180 after 5 minutes, I would make sure you have a prescription for like short acting antihypertensive that you could take in that situation. So we do that a lot, something like clonidine, for instance. So patients will just have that as a backup if they're in that situation.
Okay, somebody says, my husband's blood pressure drops sometime after standing, not immediately.
That can also happen. It's not always within the first 3 minutes. There's something called delayed orthostatic hypotension that happens after the first 3 minutes, and the effects can be the same. The important point is also, is it sustained? So is that just dropping and then a minute later it comes back up? That's normal. But if it's at least 3 minutes of abnormal, then it's abnormal. So you also, you want to do a follow-up blood pressure reading, make sure it's at least a sustained drop, probably before you treat it.
And what would sustained mean then, over some number of minutes?
Yeah, and that's not defined in any guideline, but I think most of us think of sustained as 3 minutes.
3 minutes, okay.
So it lasting, abnormal for at least 3 minutes.
Okay, and that's for the delayed orthostatic hypotension.
It's for, and I mean that sustained is in the definition of classic normal orthostatic hypotension, but
Oh, okay, all right.
that's just built into how we measure it by just just checking the pressure at 3 minutes. If it's still abnormal at 3, that means it's been sustained since you stood up.
Okay, yeah. All right, I got it. It would seem to me that this what you call delayed orthostatic hypotension has got to be very confusing for families and perhaps even for clinicians because it seems like everything we're talking about it has well it could be this, like there seems to be caveats for everything. I just don't know how families or clinicians can diagnose these things if there are subcategories, I guess.
Yeah, I think practically the point is no doctor is going to have time to measure the blood pressure, have you stand for more than 3 minutes in the office, and you're probably never going to be diagnosed with delayed OH in a doctor's office who's not an autonomic specialist. And we only really diagnose it on a tilt table test because we go for 10 plus minutes.
Mm-hmm.
So, I mean, the point is if you're feeling symptomatic, check your blood pressure and just, you want to look for trends there because all these symptoms can have other causes. And the measurement's pretty simple, but you just have to do it consistently and look for patterns. And so I put the link there in the chat to
Great.
the blood pressure log, so you can download that. And that's a good thing. You can just bring that to your doctors if you're noticing a trend.
Okay, sounds good. I've got a few more questions. Somebody asks, what about heart rate with orthostatic hypotension?
Yes, that's a very good question. I didn't go into the sort of nerdy details with that because it's a little more academic, but it can be useful. So recently, this has been something that we're using to distinguish, neurogenic, say from Parkinson's, from the non-neurogenic causes like from dehydration. So because the Parkinson's protein is deposited in these peripheral nerves, it's also deposited in those nerves that control heart rate in the heart. And so the heart can't speed up when the blood pressure drops. So you can actually calculate the ratio for every 20 points the blood pressure drops. Actually, sorry, for every 10 points the blood pressure drops, the heart rate should increase by 20 beats. So if your heart rate's not going up that much when your blood pressure drops a lot, that is consistent with neurogenic OH, and that's always the case in Parkinson's disease. So that's something to be aware of if you're on a beta blocker. So if you're on metoprolol or something, that's also going to blunt your whatever heart rate response that you have, and it's going to make orthostatic hypotension even worse. So, you definitely don't want to be on beta blockers if you have OH, unless you absolutely need them for something else.
Right, okay. Somebody asked, at what blood pressure level would you have the patient not walk around?
All depends on symptoms. So there's no number that I would say is an absolute number. It all depends on how you, if you're symptomatic, if you can walk, then you can walk. I mean, if you fall in, you're a fall risk, and even you can't recognize the symptoms before you fall, then I'd say that's a problem. But otherwise, like I mentioned, the blood pressure in the arm that you're measuring is not the same as in the brain. The brain is preserving that blood flow, and it's going to be much higher in the brain than it is in the arm. So it all depends on the symptoms.
Okay, and what percentage of people are asymptomatic? So
That's a good question. I don't think anyone's studied that, but there was a study where they did tilt table tests, and a good percentage of those patients had Parkinson's. I want to say up to at least a third of patients
wow.
either were asymptomatic or they didn't recognize the symptoms. Maybe it was cognitive slowing or a little shortness of breath, but they weren't really correlating that with blood pressure.
Hmm. Okay. Someone asked, this is a very reasonable question, I think. How can you tell if someone is having orthostatic hypotension or vertigo due to other causes?
Yeah, and vertigo is really common with this as well. So vertigo, first of all, it's going to be more likely to come out when you're sitting as well as standing. So it's not orthostatic. Vertigo is going to be more triggered by head movements, whereas OH is not. Vertigo, I mean, the classic description of it, it's more of a movement or spinning, versus orthostatic hypotension is more of lightheadedness or woozy sensation. So that's always how I ask about it. And the duration can be similar. I mean, both can last from seconds or longer. I mean, typically vertigo is more shorter acting, lasting, like meaning seconds or so, and then it's consistently triggered more by movement of the head and less by just standing.
Okay. Someone asked, can you talk about the co-occurrence of OH with AFib and whether that impacts treatment options?
Yeah, well, these are great questions because I'm actually preparing a manuscript looking at OH in REM behavior disorder, which is a bit different, but we found that's amazing, like really surprisingly, there's a very strong correlation with OH and AFib. And about 25% of patients with neurogenic OH had AFib. And there is some literature that supports this connection because AFib could be related to breakdown of these autonomic nerves in the heart. So I think that's a correlation that's not really in the literature much, and it's probably a real thing. How do we treat it? I mean, we still kind of treat it independently. Like your cardiologist is going to do the treatments for AFib, and then we're still going to use the same drugs for OH. And the drugs that we use are not going to interfere with the cardiologist treatment of AFib. I mean, if they use beta blockers, that might be a problem, but the drugs that we use are not going to interfere with the AFib treatment.
Okay. Speaking of that, if someone has OH, and Parkinson's disease, would they be advised to see an autonomic specialist or a cardiologist, or how would you determine which sort of specialist is the best?
I mean, whoever you can get in to see, or whoever's in your area, because there's not many of us. There's not many autonomic neurologists. An autonomic doctor would be the best because this is what we treat day in and day out. But most cardiologists are pretty familiar with it. A lot of neurologists, a lot of Parkinson's, movement specialists treat this. So probably your Parkinson's doctor has familiarity with all of these medicines that I talked about, and they could prescribe it as well.
Right. Okay. And is it possible to be seen at Stanford? You mentioned you sort of winced at the concept of making an appointment, somebody making an appointment. Is it possible to be seen at Stanford?
Oh yeah, definitely. I mean, we probably see the most autonomic patients of any center in the nation. So there's five doctors in our division, and yeah, we're always accepting new patients. So
Okay,
your
great.
doctor just needs, like with any referral at Stanford, they just need a standard referral, and it'll come in. And sometimes we'll do the autonomic testing as part of that. Sometimes we'll just do the visit first and then do the testing. But yes, definitely are open.
Okay, and you said and you don't always do the tilt table test. You'll do it if certain conditions warrant it. What other sorts of autonomic testing are done besides blood pressure testing?
Yeah, so we'll do a test called the Valsalva maneuver, which measures this reflex that the tilt is also measuring, that bear reflex where you blow into a tube basically, and we see how your blood pressure changes. We do deep breathing to look at your heart rate variability. That's looking at the vagus parasympathetic nerve in the heart. And then we do a test of sweating with these little capsules on your arm and leg that measure the sweat response and the small nerves in the skin. Most patients with Parkinson's disease have reduced sweating, and they have, it's probably due to that protein being deposited and breaking down those nerves. So that's a common thing that's abnormal in the testing. Whether that we're going to do anything about it, probably not. So sometimes we'll get referrals where the doctor's not sure if someone has Parkinson's disease or if they have like MSA. And sometimes there can be features on subtleties in these autonomic tests that can distinguish one versus the other. But if you pretty clearly have Parkinson's and your home blood pressure logs are showing orthostatic hypotension, you probably don't need to go through all that testing.
Okay. And let's see, there was a question that just came by a second ago. What somebody asked about postprandial hypotension, so the sort of loss of blood pressure control after eating or when someone's eating. Could you speak to that and say, is that related to orthostatic hypotension as well?
Yeah, totally related. Some people have that more than others, and in Parkinson's, these nerves that affect digestion are also impaired, and so you get kind of slow digestion, and that can be a factor. So yes, postprandial hypotension can be a big problem. Some people can faint from it, and the first thing is obviously to reduce the size of the meals, limit the simple carbohydrates. So simple carbs are the worst because you get most blood flow to your gut. And then caffeine can help. So if you have a little caffeine, maybe probably like 30 minutes before you eat, that can be helpful. But often we use midodrine. There's midodrines that short acting. So like 5 milligrams of midodrine, maybe 30 minutes before a meal. That's probably the most common, treatment that I would prescribe for that.
Okay, and again, you probably only prescribe if there is fainting or if there's some strong symptom, strong
Right.
sign.
Yeah. Oh, if there's symptoms.
Yeah,
Right.
right. Let's see. Oh, could you, we have just a few more minutes before we need to let you go. Could you just say something briefly about the long COVID research that you're involved in? That sounds kind of interesting.
Okay. What do you want to know?
Well, what does it have to do with either sleep or autonomic issues?
Well, yeah. I mean,
3 minutes or less.
yeah. Well, I don't know if you've been following the popular news, but there's another condition that probably the most common condition that we see in autonomic clinic is postural tachycardia syndrome. That's not what you have if you have Parkinson's disease. That's usually a condition of younger women, but people develop this really fast heart rate, and they can have all the symptoms that patients with OH have, and usually they're worse. But it's thought of more as a condition of like automatic hyperactivity, constant fight or flight. It's always the opposite of OH. OH is like failure of everything, and the POTS is like overactivity of everything. And so it's it can be a relatively common complication with long COVID, and we don't know why that is, but part of it could be autoimmunity. COVID activates certain antibodies that cause these autonomic problems. It could be just persistent inflammation from the virus. So, I mean, basically, we're doing autonomic testing. We're doing skin biopsy in these patients. Very interesting as we're seeing that on the skin biopsy, patients have the Parkinson's protein
Hmm.
in the skin. And this was an unexpected finding. And it's making me rethink, how sensitive these skin biopsies are for Parkinsonian process. I think it might be that certain viruses can trigger inflammation that could lead to deposition of this protein, and that might be a totally different sort of pathology than a degenerative, process.
Right.
And if there's a link, I mean, there's also been reports of patients with Parkinson's, having long COVID and getting much worse, or patients totally, developing Parkinson's after COVID. And
Mm.
so I think there is some connection with the virus, either triggering accumulation of these proteins or causing kind of neuronal injury, either at a peripheral or even a brain level, that could be related to Parkinson's disease. But that's something we'll repeat the biopsy, see if it clears. But it's about 50% of the POTS patients we biopsy have this protein, and they're about 20 to 30 years old.
Wow, fascinating. I mean, this could lead eventually to some discoveries that would help Parkinson's disease.
Yeah, I mean, if the role of viruses in accelerating
Yeah,
degenerative disease, I
yeah,
think is, I
right,
mean, in the the Spanish flu, and there are these reports, of and in the movie Awakenings is all based on potentially post-viral Parkinsonian issues. So it's something that's been around for a while. It's not really well understood.
right, right. Okay, great. Well, thank you so much, Dr. Miglis. Appreciate it. And if you could send me your slides, and I will share those online. And I also have I've copied over the orthostatics log that Dr. Miglis shared, and I'll make sure everybody receives that as well. So thank you so much for joining us.
Thank you. Enjoyed it. Okay. Thanks, Robin. Bye.
All right.